Hi, everyone, and welcome to the Students Advancing Brain Cancer Research podcast. I am Kira Levante, and our guest today is Allyson Moore. Allyson is in her third year of graduate studies and her first year of the MD-PhD program. She works in Dr. Jonathan Bramson's lab here at McMaster, and today we're going to talk a little bit about her research, which is centered around T-cell therapy for glioblastoma. Allyson, thank you so much for coming today.
Thank you for being. I'm happy to be here.
Great. Okay. So why don't we start off a little bit with your education path and how you ended up in the MD-PhD program?
Sure. So I actually started at McMaster University in the biochemistry program. I entered through life sciences and then specialized in biochemistry in my second year. I had a little bit of a non-typical, I would say, path into research. So I actually started working with Jonathan when I was in my second year of undergrad.
Okay.
So I reached out to him just looking for volunteer opportunities, and it was kind of just fell into place where I started working, doing grunt work and things, just basic things in the lab just to get my feet wet a little bit.
And at that point, was it still, it was cancer research you were doing?
Yes.
Yeah,
so
nice.
The lab focuses on T-cell therapy. My particular work focuses on glioblastoma.
Right.
So it's important to understand within the context of T-cell therapy that the tumor target or the cancer that you're targeting plays a really big role in the type of therapy that you develop. So my focus is really on glioblastoma and trying to understand how we make a better T-cell therapy for glioblastoma specifically.
And that's been true since undergrad? You've been working on glio? Oh, very interesting. Nice.
So during my second year, I was very much just doing grunt work. And then during the summer after second year, I got a studentship through BioCanRx, which is kind of Canada's immunotherapy kind of consortium. And I was able to work on a project developing a specific T-cell receptor, or not T-cell receptor, a specific synthetic receptor for T-cells that target a specific glioblastoma antigen. So I started working on that during my third year, and then I worked on that for my thesis project during third year. So I was able to do a fourth year thesis in my third year, which was really nice, so that I got more units and I got to spend a lot more time in the lab, which was really lovely. And that was a really interesting experience. And then COVID hit. So I was that year where March of 2020, I was in my third year, and then we kind of just all got shoved online for everything.
Okay.
I was really lucky to be able to come back during, I think, June of 2020. I came back to the lab and was just working as like a research assistant during the summer. Which was a very strange time working in science during COVID,
I'm sure.
And then I ended up doing another 15 unit, like full thesis during my fourth year.
Oh, wow.
I transitioned a bit away from what I had been working on for the past year and a half because it wasn't working in the way that we wanted it to, which is just science.
Right. And this was still in the Bramson lab, though?
Yes.
Okay,
yes.
Nice. Okay.
So I've been there for a long time now. I think 6 years I've been there.
Yeah.
So I've been there for a while. And then fourth year, I switched projects a little bit. And that was the basis for what I work on now, my graduate research. And then from there, I transitioned into the master's program.
Okay.
And then I did that for 2 years. And during my second year of my master's, I applied for the MD-PhD program. And I got in. So it was a very easy transition. So I'm able to continue my graduate work in the same kind of context. So I just transferred. So I didn't get my master's. I just transferred into the program. So my past 2 years of master's work applies to my PhD, which is really nice.
And you've been able to kind of work in the same field of research for the past 6 years.
Yeah.
Well, that's awesome.
Yeah, it's evolved very much from what we initially thought it was going to be. And I think that's such a big part of science where you think you're going to go and doing one thing. And if you just follow things as they evolve and questions start to pop up, and it becomes really interesting to look back and think where I started and where things kind of ended up.
Absolutely. Yeah. So SABCR usually works really closely with Dr. Sheila Singh's lab. Do you want to give us a bit of an introduction to the Bramson lab and what kind of research they're doing there? Yeah,
so we actually collaborate really closely with Dr. Singh's lab. So my work is very much a collaborative project between our lab and her lab.
Oh, awesome.
We work on a lot of the grants that fund the work that I do are collaborative grants between both Jonathan and Sheila, which is really nice because you get perspectives on both ends.
Absolutely.
So Jonathan is a typical T-cell biologist, but he does cell therapy. Like he would call himself a cell therapist. And he's worked on developing a specific synthetic receptor that was worked on for quite a while in the lab, and it's actually transitioned fully to clinical trial, which is really, really cool.
Oh, that's great.
So he comes from the side of the T cells and understanding how we make a really good therapeutic cell.
Right.
So Dr. Singh focuses more on the actual cancer side, the glioblastoma biology and other brain tumors and things. So it's a really nice kind of meshing of the two sides because
Absolutely.
both are really important to think about, not only the T cell side, but also the cancer side.
Right.
Because there's a lot of crosstalk between them and how they interact and how they kind of talk to each other is really important, and every cancer will be different. So having that expertise on the cancer side and the glioblastoma side is really, really important to the particular work that I do.
Absolutely. Is the Bramson lab, it's mainly focused around glioblastoma then?
No, so we focus on a variety of different cancers. It's kind of cancer agnostic. Like we don't really have a particular cancer that we focus on like the whole lab does.
Right.
A lot of the work focuses on multiple myeloma and other harder to treat cancers. We like to go after the ones that are a little bit more challenging,
Right.
because there's more of a space within the field for it. Because within cancer immunotherapy, the leukemia lymphoma space is very, very crowded because a lot of the like CD19 CAR T cells, those have been in trial for a while and are clinically approved. So that space is very, very crowded. The other spaces where CAR T cells don't work so well, or kind of engineered cells don't work, is in the case of solid tumors. Multiple myeloma is a hard to treat cancer, and for patients that have relapsed refractory disease, they don't have many options. So that's also an interesting space to work in. So the solid tumor side is more challenging.
Right. So when you say you try and focus on cancers that are like more difficult to treat, what's that scientific criteria that makes them harder to treat than other cancers?
Mm-hmm. So typically with solid tumors that don't respond to traditional therapy, like standard chemotherapy, radiation, those types of cancers where patients don't have many options after they've been through multiple lines of therapy and it's not working, those become really challenging. And glioblastoma in particular is very much considered an incurable disease, right?
Right.
There's really no options for patients. The 5-year overall survival is like 5%. And nothing has really evolved in terms of the therapeutic strategy for years. So it's an interesting space to work in because nothing has worked.
Right. So you're still kind of in the stage where you're just trying everything and kind of finding a lead to follow then.
Yeah. So a lot of T-cell therapies have entered the glioblastoma space, and a lot of groups focus on glioblastoma in particular just because it's such a clinically unmet need. There are no options for patients.
Yeah.
So I think there's a lot of kind of room to evolve in that space in terms of a therapeutic. But really it's challenging because nothing has worked. It's really hard to inspire people to think that something may work.
Yeah. Absolutely.
Yeah.
So any like traditional cancer treatment methods that you'd use on other cancers, do they initially work, or is it that they just won't seem to have an effect and you're just kind of going off of trying new things every day?
Mm-hmm. So there's different, I think the process in which patients go through kind of the therapeutic scheme or kind of traditional trajectory is typically, it's dependent on the cancer, of course. Monoclonal antibodies have entered the space as kind of a standard of care now for some cancers, but typically chemoradiation. For glioblastoma specifically, it's chemotherapy with temozolomide, radiation, or surgical resection. And once patients have their primary tumor removed and they can't see it, like there's no evidence that there's disease there, it almost always comes back.
Right.
And when it comes back, it's often treatment resistant. It doesn't respond to chemotherapy, it doesn't respond to radiation. And that's really where a lot of patients succumb to the disease because it comes back and it's incurable.
Yeah, so at that point, whatever treatment was used to get rid of the first time around, it's completely resistant. Mm-hmm. So you're working mostly on like reoccurring cancer.
Yeah, so I predominantly work in the context of recurrent disease, but there's a lot of interest in the field on treating primary tumors with better therapeutics, right? Because chemotherapy and radiation are pretty non-specific, but if we can bring more targeted therapies into first-line treatment, it may be better, right? So most T-cell therapies are brought into clinical trials for recurrent disease. And those patients are very sick. And sometimes they don't work fully, right? You may not get the maximal therapeutic benefit because the disease is so advanced. So there's a lot of interest in the field in bringing therapies into first-line treatment.
Okay.
But a lot of clinical trials don't let you do that because ethically you need to give patients what's standard.
Right.
And then for patients that have no options, those are kind of funneled into clinical trials for new therapies.
So would you say that because of that kind of limitation, your research is more limited to treating it the second time around than having a more permanent treatment for the first occurrence?
Yeah, so the therapy will enter through will get to patients that have recurrent disease first prior to getting to patients that have primary disease. Right. So my work, I try and focus mostly on recurrence and understanding how the cells respond to recurrent tumors because they're very different. The primary tumor doesn't look like the recurrent tumor. So when you develop therapies for a primary tumor and then it gets applied to patients with a recurrent tumor, it's not necessarily the best strategy.
Yeah.
So
interesting. So is there kind of any room for research then if that limitation exists then for more permanent treatments the first time around, or is it just really hard to get people to try or get enrolled in these clinical trials because they have to undergo the standard treatment first?
I think it's kind of the way in. I think you have to see that there is some efficacy within the recurrent population. It is a different tumor, but there are still realities that are targetable. It's just you have to understand those realities, right? So that's where a lot of the research comes in, is trying to understand recurrent tumors and trying to understand how to target them properly, right? Because a lot of what we know about antigen expression and things are from primary tumors, but recurrent tumors don't look like that. So it's important to make therapies that are focused on the tumor that you want to treat. So making therapies that are recurrent tumor focused, I think is probably where the field has gone wrong in the past. But I think there's more of a focus on trying to treat the tumor that you're intending to treat.
Yeah. So on a microscopic level, what is that big difference in a second tumor mostly that makes it so resistant to the treatment that worked the first time around?
So the cells that are left after kind of chemotherapy, radiation, those cells have inherent properties of resistance to therapy, right? You're basically selecting for cells that are therapy resistant.
Right.
And these are typically the stem-like cells. People have called them cancer stem cells. In the context of brain tumors, brain tumor initiating cells, they have self-renewal capacity. They very much act like a stem cell would act, but they're therapy resistant.
Right. So they're surviving the first time around because they are the resistant ones, and then they will proliferate.
Exactly.
And then you're left with only the resistant ones.
Exactly.
Gotcha. Okay.
And because they're stem cells, they can differentiate, right? So you end up with this hierarchy of just this jumble of different types of cells.
Right.
So the heterogeneity adds to the complexity in treating the disease, right? Because a single target is not going to get you there because you now have this really complex, diverse mass. And in the context of glioblastoma, depending on, for example, where you take a biopsy, it'll be a different tumor.
Right.
Depending on spatially where you biopsy the tumor. So it just becomes challenging because of the heterogeneity.
Yeah.
And the way that the tumor evolves from those therapy-resistant cells. So you're selecting for therapeutic resistance, really.
Yeah, I can kind of see why treating it the first time round or working on more treatments for the first time rounds might be useful if you're trying to target those cells that are really adaptive to developing resistance. Yeah. Why don't we zoom in a little bit on specifically your research?
Yeah.
What are you working on like on a day-to-day basis right now?
Yeah, so my research in general focuses on trying to make an allogeneic or off-the-shelf cell product for glioblastoma. So there's kind of multiple components to my project. I really want to work on trying to make a better therapy for glioblastoma and recurrent GBM specifically. But then there's also the aspect of trying to make a product that is more accessible by making it off the shelf. So for example, most T-cell products or engineered T-cell products for adoptive cell transfer right now are autologous. So that means that they come from the patient themselves. So for example, if I needed CAR T-cell therapy or some type of T-cell therapy, they would need to be my cells because of the specific type of cell that is used. So there's different types of T cells. When people say T cell therapy, they're typically referring to a subset called alpha beta T cells, which is the conventional T cell subset.
Okay.
It makes up most of the T cells in your circulation. But there are other T cell subsets that can be used that in an alternative fashion that can be transferred between people. So alpha beta T cells are used in an autologous fashion. So I can't give you my CAR T cells, for example.
Right.
So they can't go between patients. But there are ways that you can transfer cells from, say, for example, a healthy donor to cancer patients.
Okay.
But you have to use a different subset. There are different ways you can do this. You can use what we would consider conventional or canonical alpha beta T cells by knocking out the component that would lead to graft versus host disease, the one that would cause a lot of the problems and the toxicity. You can essentially remove it so that the cells that are being transferred don't see your cells as being foreign, right?
Right. So is this specifically would be a product that is not specific to the individual then?
Yes.
Right.
So the one way you can do it is by removing the component that would be reactive to someone else, or you can use a different subset of T cells called gamma delta T cells. So it's a very small proportion. It depends on where you're looking, but in the peripheral blood, they can make up anywhere from 0.5 to 10% of the circulating T cells. They're a very interesting subset. They're very much a blend of conventional alpha beta T cells and NK cells. So they're kind of a mix. They're both, but also neither. They're a little bit of a quirky subset. They're very much unknown to the field, and there's a lot that needs to be done to understand their biology and how they're different. So I work predominantly with gamma delta T cells because I can, for example, give you my gamma delta T cells.
Right.
And the reason behind that is because they don't recognize their antigen in the same way that an alpha beta T cell does.
I see.
So they can be transferred between unrelated individuals without risk of graft versus host disease, which makes them really interesting. But the issue is they are such a small proportion of the peripheral blood, and they're not very well understood in terms of their biology and their requirements to initiate proper therapeutic activity.
So then is your research focused on more understanding them better and seeing how they react to different things, or are you at a stage where you're really developing ways to target the cancer with using that method?
Yeah, so my work right now is very much focused on how gamma delta T cells interact with glioblastoma cells.
Okay.
Because in the context of other cancers, they behave very differently. For example, with a blood cancer like multiple myeloma, they behave very differently. When you put these cells with glioblastoma, there's a different kind of dynamic going on. Glioblastoma is notoriously immunosuppressive, and we see that within kind of our experiments where you put the gamma delta T cells with glioblastoma and they just turn off. So that's really interesting because in one context, they work beautifully and they behave exactly how you want them. And then in another context, they don't.